Good morning and welcome to Grand Rounds. If you're in the Tanglewood area, come on in. The water's fine. We're getting ready to learn a little bit about neonatal vascular access. This morning we have Angela Alderman. She's a unit director and a vascular access specialist with our own NICU here at Carilion Children's. She started as a neonatal PIC nurse in 2002. Expanded her practice to pediatrics overall in 2017. Her primary focus is on neonatal vascular access, CLABZ reduction, and decreasing venous depletion, along with hospital-acquired bacteremia related to vascular access devices. Through her work on the development of the neonatal DIVA scoring tool and algorithm, she's increased first attempt success throughout the Children's Hospital. And she was recognized by receiving the Patient Impact Award and Shine Awards in 2019, 2023, and 2024. That's a good streak. Angela has served in various roles on the Executive Leadership Council of the Pediatric and Neonatal Special Interest Group for the Association of Vascular Access. As a neonatal vascular access expert, she's contributed several publications, including PD Neo-SIG, I hope I got that one right, the PIC Insertion Course Book, and the Society of Critical Care Medicine's Fundamental of Critical Care Support in their 4th edition. Angela lectures on various topics in vascular access, both locally, nationally, and international in conferences. And she maintains board certification in vascular access and dedicated her time to that, planning and improving vascular access related to patient outcomes. And I got to say, we do a bang-up job at Carilion Children's. We've had some long streaks. We occasionally have a setback, but we have some long streaks. And pediatrics, I'm sure, is part of the neonatal, the aseptic neonatal technique. Actually, you hear about that across the system. It really got its roots in pediatrics. So we could be able to plug that. But anyway, tell us what we're going on.
Okay, thank you so much. All right, I'll walk around a little bit, picking up with my hands. So thank you all for coming. I appreciate the opportunity to present this work to you. And we are going to talk about mainly venous depletion and how we can move the needle on providing less venous depletion to our patients. So we'll get started. I have no financial disclosures other than I am employed by Carilion Clinic. And this is just an overall slide of our Carilion Children's Hospital. And then, really what we're going to talk about today is we're going to define venous depletion in the pediatric and neonatal patient, and so what that means. And then recognize the contributing factors that lead to that, as well as discuss patient outcomes. And then we'll look at some clinical decision-making tools that we have that are actually free to you all. And then we'll have some recommended practice changes. And so when we talk about normal venous anatomy, I think that we all forget that veins actually do have some smooth muscle in there. And so that's going to matter when we try to access vessels. There are valves, and then the endothelial layer of the vessel anatomy is really what creates a problem when we talk about vascular access devices. And so a lot of the problematic issues that we have with thrombosis come from that endothelial injury. So this is a little grainy slide, but I put this slide up because this person has some really nice vessels, or it appears to be that this person has some really great vessels. And, and for nurses, we're like, oh yeah, we could probably just throw a dart in that, and it's really easy to access, right? So this person looks like they have some phenomenal vasculature. But are we really confident in what we see on the outside? And so we really need to think about what lies beneath. So we can't really equate what we see with our eyes for assessment to what internally is happening in the vasculature. And so a lot of times we can't tell where the valves are. Although sometimes, if you try to strip that vessel on the outside, you can say, oh yeah, I think there might be a valve there just because of the way it refills, but we can't be certain. There are bifurcations that are deep in the vasculature that you can't a test for. And then there's thrombosis. And so from old injury, we talk about endothelial injury a lot, and I'll get more into that, but there is bruising that sometimes you can't see either. So deep bruising from previous pokes or bruising that we're not aware of, somebody hit their arm. And a lot of darker skin tone children have bruising that you can't see. And so there's a device to help us look at that as well. And then sclerotic vessels, sometimes you can tell, sometimes you can't. And oftentimes children have injuries and have previous scars in adjacent places. And so that really kind of moves the vessels to the side, or it narrows them. And so you can't really see that either. And then viscosity, a lot of our kids come through the emergency department because they're hypovolemic or they're dehydrated, same process, but you can't really tell the blood viscosity just by looking on the outside. So I like this picture of a venous valve because when you're looking at placing vascular access devices, if you look at this valve, it doesn't work.
It doesn't work on the TV screen.
All right. But if you look, this is a really narrow hole to get a catheter in, and you don't have this entire vessel length. And so it makes a huge difference when you're trying to put a catheter in a vessel that you hit that valve and you can't get through it. It also can close, and when you try to flush, it can break open that vessel. And when we talk about thrombosis, I think the biggest important thing to say is that every time we poke a vessel, we have the potential to scar that vessel down for the rest of their lives. So it just isn't the one poke and then it'll heal itself and it's okay. It really creates thrombus, and so you can have a partial or a complete obstruction, and then your body tries to help itself, and you build collateral circulation around those vessels. Those main vessels. And so we just have to remember, children are not small adults, right? So we can't equate their vessel health and preservation with adults, and for a couple of reasons. So they have immature vascular network, and I think about our preterm infants that really don't have, all of the vessels and the vessel length that we do. They have a lack of connective tissue. And so if you're looking on ultrasound and you're trying to poke a vessel, it bounces or it moves. In adults, we call that rolling veins. It's because they lack that connective tissue to kind of hold their vessel in place. And it makes it really hard when you're trying to stick something and it decides to move around. And then we have a smaller vessel length. When I talk to nurses about vessel length, I always try to have somebody come up in front of the room and say, okay, your vessel length for an adult is like from your shoulder to maybe your knuckles, right? So you have a lot of opportunities to poke. Premature infants and babies probably have a finger's worth. And so when we talk about venous depletion, they have less opportunities to poke that length. And so that really is important. And for kids, it's a third of the vessel length of adults. And so the smaller you get, the more opportunities there is to deplete their vessels. Their interluminal vessel size is a huge problem. So babies have super tiny veins, as you can imagine. Even some adults have super tiny veins, but what we really understand is that catheter to vessel ratio is important in this process because catheters should only take up about 33% of the interluminal volume of your vessel. That's really small catheters, and sometimes we don't have the smallest catheters for our smallest patients. And so if you're talking about a catheter should only take up a third of your vessel, that seems to be problematic in kids because the smallest catheters that we really have today are only 26 gauge, and sometimes they're not small enough. There is a 28 gauge PIC, a 1 French PIC that we now have access to that we didn't in the past. But the smaller that we save our patients, meaning the smaller gestational age patients, the smaller their vessels are, we've got to find catheters that are going to fit these patients, and oftentimes we can't. And so we have to use what we have. Blood viscosity is, and I have a slide on this alone, but we don't think about that as much. But the next slide that I have will kind of have a big picture of what blood viscosity can do to your vessel health when you're trying to put catheters in, because you're taking up a certain volume of the vessel, and if your blood is thick, what do you think is going to happen to that vessel? And then your dehydration, so you have a smaller circulating blood volume to your patients, and that really matters because when you're taking up space in their vessels, then you have bleeding, you obviously have some dehydration that you're treating, and so that tends to lean to also the viscosity of the blood. Skin tone really matters when you are accessing patients, and there was a study done by Milky in 2024. The authors wrote about adult patients, but it really translates to kids, that kids who have darker skin tone, we have the inability to access their vessels because you can't see them. And really bringing equity to vascular access is using tools that we have, like ultrasound, because it sees no color, right? And so we really need to be utilizing these tools in order to make equitable vascular access care to our kids with darker skin tone. We have increased adipose tissue in those toddlers. You get those babies who get past that stage and they put on fat, and you're like, I cannot see anything. Their vessels are a little deeper, and so oftentimes we don't have vessel purchase when we're putting catheters in. And so you'll get a flash, you think your vascular access device is good, and that baby moves its arm one time, and that catheter migrates out, and then it's blown. And so we don't often have longer catheters to support those children who have increased adipose tissue because we don't get that catheter purchase. There's a lot of edema when it comes to kids who have surgery, the inflammatory response, and so that edematous child that originally they come back from surgery. I think about our intestinal failure patients that have ostomies, or they get really sick and septic because they perked, and so those kids come back from the OR, and then they start to third space. And so putting a catheter in those children after they've already third spaced is near impossible. You have vasoconstriction on a normal basis when you have kids that are dehydrated, they're sick, their vessels are just as sick as they are. And so, when your blood pressure drops, of course, you're going to vasoconstrict, but you also vasoconstrict as a reflex response. And so just like if I were to poke your skin, you would pull back, your vessels do the same thing because of that smooth muscle. So when there is injury to that vessel, it vasoconstricts. And so when you're putting a catheter into that vessel, you have that primary vasoconstriction, and sometimes you don't get a great blood return, but you're actually in the vessel. So I always tell everybody to practice the pause and just wait for the flash, because sometimes it's in there, you just don't realize it. Kids are on dopamine and dobutamine. This happens a lot because your vessels are already vasoconstricted. And so then you're trying to put a catheter in a smaller hole than originally it would have been otherwise. And so who wants to talk about procedural compliance? Because I don't know a child out there that when you come with them with an IV catheter, they're going to say, sure, let's do that. They're probably going to look at you like, what? I know a lot of our kids, when babies, we can swaddle, they often don't really, we can overpower those little people. But when you start to get to toddlers and school-age children, and even some teenage children, they either already have a needle phobia because we have traumatized them by holding them down, or you're coming at them with a really sharp object, and they have that experience with other sharp things that have either cut their skin or they've been scraped. And so they're like, we're not doing this today. And so oftentimes that really impacts our ability to access their vessels because they're moving. And if you've ever tried to put a needle in a child who's moving and you're just trying to roll with them, sometimes that's near impossible, especially if it's a small vessel, which we already know is probably the greater portion of our kids, and their vessels are going to roll anyway. So being still is important. And then chronic illnesses, and so we see kids all over the health system that have chronic illnesses that have been in our hospital time after time. How many times do you think they've had a vascular access device? And then those compound. And so that really impacts our ability to gain vascular access because they've got this thrombosis already in place that we've created over time. So it's easy, right? It's going to be so easy. But this is I use pipes as really a way to teach nurses about problems with your vascular access. So I get nurses all the time we have hyperbilirubinemia patients and their blood is viscous. And so we try to stick them and the nurse is like, I got great flash and then it blew. Well, you got sludge in your vessels. So here's a picture of a pipe just to kind of give everybody a visual. So you've got that sludge in the vessel and then you're taking up the intraluminal size. With a catheter, there's only so many places that the blood's going to go. It's either going to move forward or, like the bottom picture, it's going to move out. And so those vessels often break just by flushing them or can be from catheter insertion because you're taking up that intraluminal size. And so we look at peripheral IV catheters like they're not really a big deal. And so over 300 million PIV catheters are sold in the US each year. That doesn't mean that they're all being used because we'll find out that a lot of the times they don't get inserted. And so 60 to 90% of hospitalized patients require IVs during their hospital stay, and 4 out of 5 hospital-acquired bacteremia cases are from peripheral IV insertions. And that's an astounding statistic because we always look at central line infections, but we really don't consider that we're giving our patients infections from our PIVCs. And fortunately, in the NICU, we really took this on as a project. And so our ANTT project has really proven the pudding. So we had a 74% decrease in late onset sepsis from putting our peripheral IVs in sterilely. And that's a huge jump. So we're really proud of that work, but that really speaks to the statistic. And so mortality is also associated with catheter bloodstream infections. And it's greater than 10%. And I think anything more than 1% is a problem. And so when we look at that, we can cause significant mortality if we're not careful, especially with our most immunocompromised patients. And healthcare workers are desensitized to the frequency, complications, and injury for peripheral IV catheters. And so we just think that it's necessary, right? It's no big deal. And so we often think PIVs are just okay. But this is really what happens when we start to think those things, because these are injuries that can come from our catheters. And so really recognizing that complications go way, way up when we have pediatric patients. And we're talking about their vessel size and complications with their veins. And then this causes scarring, right? And so then our ability to come back to these patients and start an IV is almost near impossible. So what does Oprah say? You get an IV, and you get an IV, and you get an IV. Everybody gets an IV, right? And we often see this in our emergency departments, where kids come in, and what happens first? They get an IV. Do they need it? Maybe. But we always put one in, right? And so the just-in-case IV shouldn't happen to our kids anymore. There have been several publications written about this, And 40% of all PIVs that are placed are not used. That's an astounding statistic, and that's for all patient populations. And so when we think about putting in vascular access devices, that's something we really need to consider. Are we really going to use this device? And so the cost adds up. And it leads to unnecessary trauma and pain for the patient. And I think that we really can't quantify that as much. But you have to understand that in infants and children, that is compounding, and it creates a mental and emotional problems for them lifelong. Especially our babies in the NICU that get approximately about 23 painful procedures a day, from heel sticks, IV punctures, movement, intubation, those kind of things. So this is a contributing factor. But just to say, and it is estimated that about a peripheral IV takes about $31 to insert, including your time as well as the supplies. So it's $31, and that's if you don't have a difficult patient, right? So that's if you get that first attempt success. That doesn't equate to difficult venous access. And so I just wanted to point out some numbers from our own children's hospital, just because we've been collecting ANTT data to really give the cost to this. So we had over 2,000 unsuccessful insertions, and that was, successful insertions, and that was about $68,000 worth of IV cost. And those were our successful attempts, but that doesn't mean that they got them on the first success. So this number is probably at the lower end. What really I looked at was the unsuccessful attempts in order to get the successful attempts, but understanding that that data is also skewed because if you aren't able to get an IV at all, and you've tried multiple times, that is not included in this number. Because currently in EPIC, we don't have a good way to track that to say, oh, this patient was poked 6 times in the emergency room. The only unsuccessful attempts that we can capture in EPIC are really from if you get an IV at all. And we know that there are some kids that we poke several times and they never end up with an IV, but the person who finally gets the IV in is only going to count their unsuccessful attempts, not Mary Jane, who just poked them 2 hours before, right? And so we had a total of about 3,469 attempts that were recorded, and that totaled about over $106,000. So that's a lot of money, and doesn't equate for nursing time as much. And so in pediatric, when we talk about PIVs, there was a really nice article done by that Avatar group. They study vascular access in Australia. Tricia Clyden and her team really look at pediatrics specifically. And so they talked about peripheral intravenous catheter care bundles as an improvement initiative. And what they really found was over 50% of children needing PIVC insertion have difficult access. So half of our kids already, hands down, are divas, right? And so the failure rate is what is most important, because in kids, it's estimated that 50 to 60% of all peripheral IVs that we insert in children fail before completion of therapy. And we know this in our practice, we've seen it. And I think it has to do with our challenges, right? So our vessel length, our vessel size, the repeated pokes. And so this really happened. This 22 pokes really happened. There was an 8-year-old on the Peds floor with a primary diagnosis of osteomyelitis. This child got poked 22 times in less than 12 hours. That's unbelievable. But it happened, right? So the kid comes in, gets poked in the ED for a PIV and some labs, right? Because, we try when we poke kids to only poke them once. And so they were unsuccessful in all attempts. The next person comes and tries with 2. Then there's 4 attempts. Then there's 2 attempts. Then there's another 2 attempts. Then there's 4 attempts. And, you see as a progression comes on the 22 pokes ended up getting 1 peripheral IV. They did get some lab work, but was this the appropriate escalation pathway? And there was never a provider that was notified other than when we went to go get that IM antibiotics. And you see how far down the list that is. And so escalating and trying to figure out something different is so valuable. Because repeated catheter insertions lead to a lot of different things, infection being the primary concern that we have in the NICU, because pokes in the skin lead to infection, and just as in the adult population and pediatrics. And then there's tissue trauma. And so a lot of tissue trauma can cause scarring and can move things around or inhibit your range of motion. A lot of times there's mechanical injury that we can't see to the vessels. And then there's pain, bruising, bleeding. We talked about injury of adjacent structures. There can be death. And it really leads to this endothelial injury cycle. And this is where thrombus are created. And so I like to put this slide up here because, you go back to, it just goes in a circle. So you get that vasoconstriction of the vessel, then you have your body trying to help you with the primary hemostasis and platelet adhesion. You get down to the secondary hemostasis, which you get that clot to try to seal off that site. And then it decreases your blood flow through that area or obstructs it. Then you have a thrombus formation. It increases further injury to that endothelial layer of the vessel. And then you start to have that cascade of inflammatory responses. So it gets really angry. And so your body keeps trying to fix it, but it keeps going in this vicious circle. So what happens overall is that you really start to deplete your vessels. And so it's the same thing for repeated pokes and effects of venous depletion, but we see that we have experiences for patients and family. It delays treatment. This is really important in our HEMOC patients because if you have an interruption in therapy, it increases their mortality ×3. That's terrible. And so we don't want interruption in treatment. When you're trying to help with sepsis, there's an important piece to getting your antibiotics to them on time. And so it increases our morbidity and mortality. It increases our risk of DVT. And there was a little study out probably about 10 years ago that looked at 20 and 30-year-olds that were coming into the emergency department and they had DVTs. And nobody could figure out why they had DVTs. They were coming in and complaining of symptoms and nobody was looking for it. And then finally, when they found this DVT, they're like, what is going on with these patients? And so when they did a retrospective study and reviewed those patient cases, they found that they had a history of prematurity. And so we have poked their vessels so many times and depleted them and created all of these thrombus that now they're starting to have DVTs later on in their life. There's an increase in surgical line placement. So who's been in the PICU and, we have exhausted all of our vascular access and you've got all of this venous depletion and there's nothing else left. So the kid goes for a cut down, right? And so it's happening in the NICU as well. We poked every vessel that we can. These are really sick kids and we've ended up with fem lungs that were not necessary for these children. And then it's an interruption in nursing workflow. It obviously increases our later vascular access complications, which I worry about because you've got a kid, you deplete them when they're here in the hospital, and then they have an emergency, right? And so they fall off their bike or they get into a car accident and they're coming through the trauma bay. How easy is it going to be to gain vascular access on those kids moving forward if there's a true emergency? And so I see that we're going to have an increase of IOs and things that we're not going to want to do for those children moving forward when it's a real issue. It increases our length of stay, and that's got a $sign on it because anytime that you increase your length of stay, there's money attached to it, and there's obviously reimbursement models where we don't get reimbursed for that. And so it decreases our satisfaction scores for our patients and families. Nobody wants to have their child held down and repeatedly poked, and when families look at that or they witness it, it's traumatic for them. They don't want to come back to our facility. They're like, no, they put my child to death while I was there. And then unnecessarily central line placement. So when a patient could have gotten away with a peripheral IV, we're putting central lines in because we've run out of spots, right? And so what does the evidence tell us about insertion attempts? Like there's a 54% increase in complications when 2 or more puncture attempts are performed. And I don't know about you, but that is a frequent occurrence in pediatrics altogether. And then their inserters with less than 50 vascular access device procedures have a greater than 50% risk of a complication occurring, and they have more difficulty achieving successful insertions. So simulation is going to be really important. And so we'll talk about specialty teams toward the end, but this is why. When there are inexperienced people putting in lines, those complication risks add up. And so I really love this video, and I hope you enjoy it. So this is, in nursing, we really have this idea that if we can insert an IV, then, that makes us a great nurse. And so this is a clip that I found from Nurse Blake. I have to give him credit. And so just watch this clip about him getting.
One platform, any website, unlimited creation.
Hey guys, I don't want to interrupt, but I just put in this amazing IV in room 5. It is a 20 gauge. It's in the left antecubital fossa. If you want to go take a look, I mean, I don't want to give myself a pat on the back, but it is pretty much textbook. Hey guys, I just inserted this awesome IV in room 5. I mean, it's pretty textbook. So if you want to go take a look, oh, and there's nursing students here, you definitely have to go, and show them. And listen, if you have any hard sticks or anything or need help with tips and tricks, be sure to get me. I'm gonna just be like the IV super user on this floor. So I'm with this patient, right? I'm inserting an IV. I just use one tourniquet. Her veins are rolling, but the way I was able to anchor it down was crazy. I got the flash, I dropped the angle. At first I started with a 26-degree angle, and then right when I got that flash, it was like boom. And then I dropped that angle, I advanced it about 2.5 millimeters, and then I was able to advance the catheter, and it was like, perfect. Yeah, you definitely have to take a look. I think everyone's been talking about it. I'm actually looking for a full-time job on the IV team right now, since I'm so good at those. And it was like, boom, I saw the flash.
So, we think that just because we get that one successful IV, that makes us an expert, or that we are now vascular access specialists. And so I think that has been a culture of nursing, is that if you can't get your IVs, you're not a good nurse, or for residents or medical students, if we can't get our IVs in, that makes us not good clinicians. And that's not really true. We need to think about what our goal of therapy is. And so when we talk about decision-making in vascular access and venous depletion, our decisions prior to inserting the device really matter. And so we need to pick the right clinician for the right patient at the right time with the right vascular access device. And sometimes it's hard to do that, especially if the kids come through the emergency department and you really don't know why they're there. But planning ahead of time makes a huge impact on their stay and their venous depletion. And so I always say, keep calm, don't be a diva. But this is the diva scoring tool that Dr. Yin originally crafted in the emergency department. And Dr. Riker continued this work in studying what tools or clinical decision-making things can we have in the emergency department to really say who can stick this patient. And so it looks at this predictability score. And so if your score is 4 or higher, then it's your 50% likelihood of a failed first attempt, hoping that when we have this tool that we'll make better decisions on who hooks the patient. There came a peripheral IV insertion algorithm from Dr. Weber at CHOP. And so I share this with you because we have our own diva scoring tool and algorithm that was kind of pulled from this literature and these talks to really say, to include our NICU patients. And so I was able, in some of my work, to really look at the diva scoring tool and what impacts our patients, to create a modified version of that so that it would include NICU babies. And so this is a tool that I've adapted and have spoken on, really noting that if you look at our age categories for the NICU, it looks inverse because most of the time, and I don't know if you know this, we can't give blood through our PICCs. And so a lot of our patients get PICC lines, but you can't infuse blood through them because the intraluminal size of their PICC lines, it would clot their line, which is life-saving for them, right? And so we start IV catheters to give blood transfusions. And if you know anything about little babies, we deplete their intravascular volume just by lab work alone, although we try not to do that. They get repeated pokes. So the older our NICU patients are, the harder it is going to be to access them just due to venous depletion. And then this is our actual algorithm from our hospital. And so it really looks at a decision tree as to, you know, how many attempts, if we know that they're difficult vascular access versus if we don't know, and really using that predictability scale in order to say, hey, this patient's going to be really hard. Maybe we should get someone else that has more experience than I do, right? And so there's a lot of decision-making tools out there, but sometimes you just got to have a little magic. And so this is the Michigan Appropriateness Guide for Intravenous Catheters in Pediatrics called Mini Magic. This was a panel of experts that came together that were interdisciplinary. So they had lots of people on this panel, people that were really well-versed in intestinal failure. They had oncologists, there were epidemiologists, and then, you know, your vascular access experts to really determine what devices are appropriate for which patients. And so they looked at device characteristics, the rationale behind them, and really had this cool algorithm in order to help us decide which devices are appropriate. And so there is an app for that, and it's free, and you can put it on your phone. You can do, and it is available on Android and iPhone, and so it is a free device, and it's a good clinical decision-making tool if you've got a kid and you're just really not sure what to put in. And so it does take special considerations for your intestinal failure population. It looks at their age range. It also looks at your cardiac kids, so it'll tell you upper limb versus lower limb placement. And your hematology oncology patients, some appropriateness for them as well. And so I encourage everybody to download this app and to use it because it's really helpful sometimes when you're not really sure what device is appropriate. And they have like a yellow, green, red, kind of a stop sign thing is that, yeah, most of the time experts say that this is the correct device. You could put in this device in the yellow, but you definitely don't need what's in the red. And so we have a lot of visual vein technologies that I think that we don't utilize very often. And so I'd like to speak about those. And so we have a near infrared light, and this really uses the hemoglobin in the vessels to kind of display kind of, you know, where your vessels are. So it uses that hemoglobin as a reflection for your vessels, but it doesn't tell you depth. So the thing that I like about this device is it's for vascular assessment. So you can assess your veins with these devices. So you can take this, you can look all over the extremities and say, oh, okay, you know, I see that there's not a lot of refill right here. So that might be a stricture, or we may have an obstruction, or there might be a valve there. And so you can really assess your vessels really well and know where the breaks in your vessels are from near infrared light. So it's a good tool to just kind of do an assessment. I don't like sticking with these, although people do and have good success in sticking with visual vein technology like this. But ultrasound is kind of the golden standard for that because you can actually watch your needle go in the vessel. Transillumination, we sometimes use it in our NICU babies because their skin is very transparent and there's not a lot of layers. But transillumination is also used by our PICC and vascular access service. I know Trey, I'll give a shout out to him because he has a transilluminator that he uses and is very successful with it and sticking the patients on the Peds floor and has gotten really good at that skill. So it's just another tool that we can use in our toolbox in order to gain access with our patients. We talked about this study about health disparities in peripheral vascular access outcomes. And blue light utilization is really good for your darker skin tone children that you can't readily see bruising. And so I like the use of blue light. I mean, we have it in our phototherapy already in the NICU, but it doesn't take a lot to shine a light on a darker skin tone child to say, oh my gosh, I didn't realize that you had a bruise right up above your antecubital fossa. Maybe I shouldn't stick that arm because there may be some damage to the vessels there. And so really using that technology in order to provide the best place for our catheters. And then ultrasound, obviously I mentioned before, is kind of our gold standard when it comes to really gaining great first attempt success. And so it's, you look at your success rates with other visual vein technologies, and ultrasound really does bump up our first attempt success into the 90s to 100%. And so really utilizing that device to our advantage, although challenging because we don't have procedural compliance, and in order to use this device, you have to have someone sitting still. So it does make it complicated in pediatric patients. So what about the placement? Why does that matter? Well, I can tell you that placement matters. This is from Cincinnati Children's Hospital. This talks about flow and vessel length, and vessel size. And so your vessels, as you get to the center of the body, obviously get bigger. And so just to point out on this particular slide is that your blue and green vessels probably dilute the medication by 3%. That's what you get. And so that 3% dilution matters when you have caustic medications going in vessels, and they're most likely to create that endothelial injury and break open your vessels. And so that's why our peripheral IV catheters don't last long. Then you get up to the elbow and you start to get in the yellow zone. And so the yellow zone is about 20%, but I really want you to pay attention to this because that yellow zone only goes up to about the top of where your subclavian vein kind of meets your superior vena cava. And everybody thinks that if you pass mid-clavicular, you're central, but that's really not the case. And you can create a lot of issues with having lines, especially central lines, that are just right there where the collarbone and that first rib kind of meet, because it narrows the vessel in that place. And so you have that pinch off. And sometimes you can't get catheters past the pinch off, but it's a good idea to leave them there. We found out, no, they infiltrate there, and quite frequently. We've been looking at our complications specifically in the NICU. As our babies get bigger, their catheters migrate out. And so then what used to be a central line is no longer central. And then when you get down to your superior and inferior vena cava, that's the sweet spot. That's where we like to put all of our high-risk medications. And that's because you really get a 50% dilution in those spaces in the vessel. And so when you think about that, where you're placing catheters can really matter. And this is important because Cincinnati was really ingenious in putting a medication list that actually matched the vessels. And so looking at the extravasation risk and saying, okay, here's the green vessels, here's the green meds that would probably last longer in these vessels, right? So infusing longer in those peripheral IVs versus maybe we should put a catheter in a different place. So past the antecubital fossa, because maybe that your bank and some of your other what they consider yellow risk meds would do better in those vessels versus what you need to have in a central location in your central vessels. And so this is the red, yellow, green chart. These are hanging up on the pediatric floor as well as in the NICU. And so really looking at where you're placing your device could be important as to how long your catheters are going to last you with the medications that you're infusing. And so looking at this list and saying, oh, you know what? Maybe I should try to find a vascular access device that goes in a different place so that we might be able to complete our therapy. So just to give you an idea of where we are as a children's hospital, Angela Wolf has been doing some incredible work with tracking our infiltrations and extravasations with our peripheral IVs. And so she did this slide actually yesterday in Vascular Access Committee, and I asked her to borrow it for this. And so, this just kind of shows that most of our vascular access devices were not placed in appropriate veins for the medication that they were receiving. And so we look at PICC line placement and really where our PICCs and central lines should be. And it really should be the lower 1/3 of the SVC, which is about 1.5 vertebral bodies from the carina. And obviously can be placed in upper and lower extremities. And then I really love this slide. Cincinnati Children's does a lot of research on vascular access and vascular access devices, and they've really given us a really nice tool. So this is actually on their website, and you can find it also on stopivharm.org. That will tell you appropriate placement for upper and lower limb target positions to try to decrease your complications and thrombus risk to those areas. And then before I get into special teams, I do want to address Dr. Temez's question about how do we get proficient with vascular access, and it really has to be with simulation. There's a lot of mechanics that go in, and you know, if you don't get the practice, then you're not going to get better. But I think there are some patients that have good vessel health and preservation that we have our learners stick, and then there's those patients that are already venous depleted, and we don't have our learners stick. And so if you look at our IV algorithm, it does say if it appears that the veins are palpable and visible, then yes, our learners can stick those patients. So it doesn't say that no one can, because we have to grow our vascular access team, right? And so that's what I'm going to talk about next is vascular access in their specialty, because just like cardiologists or gastroenterologists, like we have specialty services for children that specialize in that one thing, vascular access services specialize in vessel health and preservation. And so I do agree that there has to be simulation. There are simulation models that are more lifelike that we can purchase now that we haven't had in the past. There's also a really cool way to do virtual reality simulation now with vascular access. It's upcoming. It's not perfect yet, but I do love it because it takes you put a virtual reality headset on to stick. And so it's really neat.
Imagining someone with their eyes covered with a needle
Yeah, so I mean, it is funny looking. There is a clinician with Ava, and he's wonderful, that does virtual reality sim, and he has a business for virtual reality sim, and so they presented at a conference this year, and I tried it on, and I was like, I am going to fall down. But it was really neat because they took vascular access experts and they put gloves on them in order to mimic their movement, right? And where their position, their hand position, their body mechanics. So there is a lot of work being done with that, and hopefully we'll see that come to fruition in trying to teach people. So it's upcoming and it's new, but it's cool. So let's talk about special teams while we still have some time. So why do we need them? There are inconsistencies in standard practice, and this really contributes to our higher incidence of complications. They improve first stick success, meaning that they know the tools to use and the devices to select. They'll decrease waste, and as we've seen with the peripheral IV catheters, decreasing waste and having that lean methodology is so important. We'll improve efficiency. We'll decrease our length of stay, obviously, improve our morbidity and mortality rates, which we have seen in NICU with ANTT. Fewer needle sticks. And I don't know about you, but I don't come into a hospital and say, oh yes, I want 3 needle sticks for this one IV. No, everybody wants their first attempt success to be good, right? We'll have time reduction between devices, meaning, if you lose your PIV, then you'll get one pretty quickly. And then decreased time interruption in treatments, which we talked about our oncology patients and how valuable that is. And then a reduction in moral distress for staff. And, this really does tie into nursing turnover, because I can tell you from doing this job for a number of years, especially when I come in and tears start to flow off children's faces because they know why I'm there, right? And no one likes to be the person to inflict pain on others. And over time, that kind of adds up. And so it is impactful as a moral distress piece because there are often times where we are sticking patients that we know it is not the right device and it provides moral distress to us because really the appropriate device should have been a central line about 2 weeks ago. And so understanding that that also contributes to staff turnover because they don't want to do it anymore. They don't want to inflict pain on children. No one does. And so you have to consider that piece and really that importance in this particular field. And so they really function to develop and foster a team approach to IV therapy. Having vascular access, especially consulted, really can say, you know, we think this is probably the best device for your patient, and having that plan ahead of time, even if you've got positive blood cultures, starting that conversation early can really help you get the right device in that child so that it's not repeated pokes. Creating a systematic approach to difficult vascular access. So if you already know this patient's coming in and they're already difficult, you know, having that plan in place and really exercising that knowledge for those specialists, they can help you. Coordinating evidence-based practice, they standardize their insertion care and maintenance practices, which will also help us in our vessel health preservation because we'll be doing what's right for the lines. And then we'll assist in clinical decision-making, eliminate medical waste and inefficiencies, and then provide equitable vascular access care. And that's very important to give everybody the same type of care. And equitable, not equal, right? And so this is just a list of resources that on organizations supporting the use of vascular access specialty teams. I know that we are expanding our practice as far as our adult PIC team, where they're now incorporating, they're getting ready to do a service, a vascular access service. And so that will be very helpful because they will be all encompassing, so they'll be able to be consulted to help you in our journey to really provide safe care for these patients. And then there are tons of guidelines that support the utilization of vascular access services. And so these are just a couple of guidelines. The Inpatient Nurses Society really, though, is probably the gold standard of vascular access care. And they have their 9th edition that has just been published last year. So if you don't have a copy of it, I recommend that you do. They have lots of great information about device selection, maintenance care, and insertion. And that's really what we follow as practicing vascular access specialists, as well as the NAN guidelines for neonates. All right. Okay, I do still have time for questions, like 4 minutes, but thank you all for listening to my talk and obviously for protecting our smallest patients and preventing vascular. Questions?
Angela, thanks for this presentation. It's something that learners in medicine should be introduced early on. And a couple of things I'm thinking about with this, like the vascular access service and prioritizing. I'm thinking about folks who were receiving CED and then receiving services in the hospital. Probably the majority of those patients would fit into a high-risk vascular access situation. And so I wonder how, the mechanics of helping improve vascular access and safety of it may contrast or may help other platforms like sepsis response. I would imagine that sepsis response has to happen at a certain time, a certain identification, time and fashion, time to medication therapy begun. That may be in direct contradistinction to ideal safe access modality.
Yeah. So I will tell you that most hospital systems are moving to vascular access service, and part of that service is 3-armed, right? And they've taken over all PIVC insertion for all patients in the hospital. My friend Lee Steer, who works for a hospital system in Hartford, they have taken over that entire, all the vascular access is provided to their patients in their hospital. Their vascular access service does, but they also have a large team. And so part of that team is having people that are dedicated to peripheral IV insertion, and they prioritize that in the emergency department or when you're having a sepsis case. And so part of their service is to provide that timely vascular access like you're talking about with that particular team. And so I will tell you that a lot of institutions are moving to service. Cincinnati Children's Hospital has one of the best vascular access team services, and they have 40 FTEs for their hospital. I don't know that they insert all of their peripheral IVs yet, but they are moving toward that. And so really helping to have timely vascular access. And they have a 24/7 service, which is where our hospital is going with our PIC and vascular access team, is that they are moving toward a 24-hour service. Does that answer your question?
Dr. Keel, did you have a question or comment? See if that hand raised.
I did. I just had a comment. I really love Angela Wolf has done a great job, as Angela Alderman said, at gathering, looking into the PIVI information that we have and gathering that. And she and I were spending some time going over it. And I want to point out just a good example of how this applies in the real world. Acyclovir is a red drug and so very high risk of extravasation and can be dangerous when it extravasates. And yet we have a lot of neonates that we do full septic workups on, and often that includes acyclovir for a short period of time. So I just, according to that chart, if you were just to take everything rigidly, we would consider, you could potentially say, oh, this little 2-week-old that's getting a septic workup and needs acyclovir needs a central line. And I want you to keep in mind that these are just guidelines. And, often we completely ignore them. And I hope that after this talk, we won't completely ignore them, but that we'll use some common sense as well, in that we're not putting a central line in every septic workup that we do. Just be cognizant. If you have 2 different sized IVs and one is a larger one and a bigger vein, maybe, ask the nurse to put the acyclovir through that one instead of the 26 gauge that's in their in their hand. That might not be the best place to put acyclovir. So just keep in mind, these are guidelines, and we just want to do everything we can with the information we have to take care of our patients, and being cognizant of their vascular access is a big part of that.
Thank you, Dr. Keel.
Thank you.
Thank you, Angela.
Welcome.
One more comment. Probably when we are admitting patients or talking about patients, we say, oh, we need to put an IV in this child, but gosh, he's a diva. When we were talking about the cow.
Well, and to your point, and something that I failed to mention earlier was that Iowa State Children's Hospital has really looked at, does everyone need an IV, and can we do sub-Q fluids? And that is something that they're looking at in their emergency department, which I think can also help your vascular access. So like if you've got a dehydrated patient, you could try sub-Q fluids, like a slow infusion of sub-Q fluids, so that you can actually get your vessels to have a little bit more volume, so that, you initially start those sub-Q fluids overnight with a slow infusion, and then the next day call someone to put an IV in. And so sometimes that will also help you. I have not seen any published studies from their project yet, but they presented it at conference last year that they were trying that in their emergency department instead of repeatedly poking their kids.